Thank you very much for the opportunity to talk to you about PTSD and alcohol dependence. It's an area of interest for me in terms of research. We'll say a little bit about the epidemiology of these co-occurring disorders and how they interact, how PTSD and substance use interacts. And those interactions are really rich and complex and multiple. And I'm not going to be able to do justice to the complexity of this topic, but we'll cover some of it and something about treatment, and I'll give you a little glimpse of some of the research we're doing at the VA right now in this area. So, as clinicians, we face all kinds of challenges in working with substance abuse patients because the majority of them have some sort of other non-substance use Axis 1 psychiatric disorder and often Axis 2 disorders. PTSD is certainly one of the many psychiatric disorders that co-occurs with substance use, we'll talk about these interactions, but it's difficult to manage these patients because the co-occurrence complicates things. So PTSD and substance use are both each independently fairly common disorders. They co-occur, they share some neurobiological and other relationships, and they cause problems for us in terms of how complex it becomes to assess patients and then how to manage them, either psychosocially or pharmacologically. And the co-occurrence of these problems tends to worsen treatment outcome for each of the independent disorders. There's also another aspect of this that I'm personally increasingly interested in, and that is that PTSD and substance use share a lot of features in terms of various forms of neurocognitive impairment, among which are various types of impulsivity. So risk-taking, poor decision-making, impulsive behavior. Of course, there are many other psychiatric disorders that have neurocognitive impairment: attention deficit disorder, schizophrenia, even severe major depressive disorder. When someone's caught up in a profoundly depressed episode, it restructures your cognitions. It skews the way we think. But in PTSD and alcohol, and in the left-hand corner is another new interest, traumatic brain injury, which we're seeing in a lot of young people who've had sports, people who've been, of course, assaulted, and then veterans, a population that I spend a lot of time working with. But each of these independently, substance use, traumatic brain injury, PTSD, each can contribute an element of additive, incremental neurocognitive impairment, with impulsivity as being a common sort of pathway that flows from these. And the problems with impulsivity are multiple. In addition to just maintaining substance use through poor decision making, there are other risky behaviors: suicide, assaultiveness, marital disruption, job loss, accidents that all flow from this. So it's an important area, and if we have a chance, we'll touch on that. So just a little bit about the epidemiology of these disorders. There's a large interaction in patients with lifetime PTSD. Various studies show that the rates of a substance use disorder are 30 to 40%. And by the way, it's difficult to get exact numbers because people vary, and the populations studied are really heterogeneous. So is one looking at a community sample of people with PTSD, or a mental health clinic sample of people with PTSD, or some other setting? And depending on the setting, you get very, very different rates. But it's enough to say that probably have 3 to 4 times the rate of substance use in PTSD patients as you have in the general population of individuals without PTSD. And similarly, if you look at the other side of the coin, looking at substance use disorder patients, the prevalence of lifetime PTSD ranges from 26 to 53%. So again, probably 3-4 times what it is in the general population of people without substance use. So either way you look at it, the co-occurrence is high. And this is just data from the San Francisco VA Medical Center, looking at the last few fiscal years. And what it shows, the gray bar on the left is the proportion of veterans at the medical center And at that medical center, we see about 40,000 veterans from San Francisco and the area north of here. Of those, about 6,000 or 7,000 are diagnosed with PTSD currently. And of that 6,000 or 7,000 who have PTSD, 30 in fiscal year 07 it was 33%. In fiscal year 11 it's about 38%. So if you look at the medical charts of those patients, about 38% have some substance use diagnosis if they have PTSD. And again, that's about 3-4 times what you see in the veteran population as a whole. The red bar, or the smaller bar, is just the subset that has alcohol, because that's a special interest of mine. But roughly a third or more, 30 to 40% of these patients have some substance use problem. So what are these relationships? And I'll just use alcohol as a kind of an exemplar because it's the most common substance. But we often hear this explanation, self-medication, and very interestingly enough, this started out as a clinical concept, but you hear it from a lot of patients. I mean, those of you who work with clients and patients know that patients will often say, I use a drug or alcohol to self-medicate. And they'll actually use that term. They won't say, I'm using it because I'm sad or I'm suffering. I'm using it to self-medicate. Self-medicate my ADHD or my depression or my anxiety or because I can't sleep. And PTSD patients also say that. They'll tell you they drink so they can fall asleep, or they drink so they won't have nightmares, or they drink so they won't be so irritable during the daytime, or that they won't be so bothered by intrusive, unbidden recollections of traumatic events. And there's something to this. As an addiction physician, I'm more likely to want to think in terms of alcohol and substance use can drive some of the PTSD, can make it worse. But in fact, it seems the directionality certainly comes a lot from the other direction, that PTSD symptoms really do tend to increase or be correlated with increases in substance use. And I'll be showing some data that shows that PTSD treatment can actually help perhaps reduce some aspects of substance use. I think we're just beginning to discover whether treating substance use can in turn down some of the intensity of PTSD symptoms. So, I think simply put, one can say there's a bidirectional relationship. It's not substance use causes PTSD or PTSD causes substance use, but there are relationships that go in both directions. So alcohol and substance use certainly is a risk factor. All the data shows that for people to develop PTSD, and we'll get back to that in just a moment. There are many ways that can occur. Alcohol and substance use can also moderate, so they can be moderators. If you've got PTSD, if you're doing a lot of alcohol and substances, that will affect your PTSD symptoms. It'll affect your level of impairment, your level of functioning. And alcohol and substance use, perhaps because of the self-medication issue, are also consequences of PTSD. So really the relationships are multiple, and it's not really possible to, in some simple way, to summarize one way that these things interact. It's complex. It differs with every patient. And then even in one patient, the relationships can be multiple. And it's as with most things in mental health, and addiction, we face complex, difficult to summarize and difficult to simply characterize disorders. It's a classic problem with mental health treatment, isn't it? That it's hard for us to actually assess patients accurately, to agree on diagnoses, and even when we do, it's very hard to predict the outcome of our treatments. It's a special challenge that we have in the part of healthcare that we're involved with. So, I'm not going to get excessively into this, but alcohol use disorders and substance use in general and PTSD also share some important neurobiological mechanisms. What's wrong with people when they have PTSD? Well, that's a complex question, and I certainly don't have one answer, but certainly among the things that are wrong are neurochemical alterations in various brain regions that involve cognition, that involve mood, anxiety, depression, that involve arousal, our alert systems, the systems that are responsible for fear, for identifying threatening stimuli in the environment, for remembering the connection of stimuli to what happens. So In an oversimplified way, people with PTSD have disordered arousal systems and remain either aroused all the time or become aroused through from inappropriate stimuli that aren't really threatening. And so there's this permanent state of arousal systems being turned on. We have examples, I mean, right now at Alta Mira, we have probably several patients here, mostly women, mostly young women who've had traumatic sexual experiences or who suffered other childhood adverse events or adult sexual assault during periods of substance use or maybe even at other times. And one thing that we see commonly are nightmares. Nightmares, night terrors. And so we're, in addition to trying to apply trauma-focused psychotherapy, Dr. Eddy and others here I think are quite interested in that. In addition to that, we also try to intervene pharmacologically using some of the strategies that we use with veterans at the San Francisco VA Medical Center. So using agents that down-regulate excess adrenaline, blood pressure medicines like prazosin, for example, that have been shown to help veterans reduce nightmares. So the co-occurrence of these problems, these two problems, alcohol and substance use and PTSD, lead to a lot of different complications, worse outcomes, more complex treatment, higher rates of relapse to substance use, and so on. Many of you may be familiar with Lisa Najavitz. She's a psychologist who's become very well known for her work in PTSD and substance use. She's based out of Harvard and has developed a strategy, Seeking Safety. I'll be saying a little bit about that. Seeking Safety is essentially an individual and group-based psychotherapy that attempts to deal, I think, initially mostly with women with PTSD and substance use, but it's been applied increasingly to both genders. So this is just from a very nice review that she and Ingo Schaefer did on the relationships between PTSD and substance use. And some of the, we talked about PTSD can lead to substance abuse or can moderate or exacerbate substance use. And why might that be? Well, there are a number of different reasons for that, but certainly one is if you have childhood traumatic stress, there's good evidence that individuals who are exposed to severe childhood adverse situations, abuse, sexual abuse, neglect, other forms of stress, that this can actually affect the brain and behavior in terms of reducing the individual's ability to self-regulate, to regulate affect, to regulate risky behaviors, to self-soothe, and that those vulnerabilities can increase the vulnerability for substance use because substance use offers chemical opportunities for altering internal mood states. So it's a natural consequence. And so PTSD patients may then, and this gets us back to the self-medication concept. Substance use, though, is also known to do the reverse, to heighten the likelihood of risk of PTSD. One mechanism is by increasing your chances of being exposed to trauma. So again, patients here at our program, a number of them have had various traumatic events, assaults, sexual assaults, other bad things happening during a career of substance use. And so that can absolutely create the opportunity to develop both acute and chronic traumatic stress reactions. And then, interestingly enough, a different relationship that Schaefer and Najavitz proposed, which is substance use may produce a higher probability of developing PTSD if you've been exposed to trauma. So not only can substance use increase your likelihood of encountering a trauma, but it can worsen your response, your neurobiological, psychological, behavioral response to trauma once you've been exposed to it by affecting the vulnerability by weakening one's adaptive capacities, weakening cognitive processes. So weakening the ability to make good decisions, weakening the ability to process affect. Substance use can make one vulnerable to having a bad outcome from exposure to trauma. Then both PTSD and substance use, the relationships can also be mediated by other variables such as deficits in coping skills that might exist independently from either the PTSD. Edna Foa, who, again, a number of you may be familiar with, she's a psychologist working in Philadelphia who's just finishing a large study on combining exposure therapy and naltrexone, the alcohol treatment medication, combining that with exposure therapy in individuals, non-veterans with PTSD. We don't know the results of that study yet, but she conceptualizes substance use and PTSD as having a vicious, cyclical kind of a relationship where each worsens each. So the worse your PTSD symptoms, the more substance use you might engage in. The more substance use you engage in, you further downregulate neurotransmitter systems that are needed to maintain normal mood. You further impair your ability to think clearly, make right decisions, to regulate your own affect. For example, alcohol abuse can impede recovery from traumatic experiences and contribute to the maintenance of PTSD. PTSD further escalates and entrenches alcohol and other substance use. So how do we treat substance use and PTSD? Well, there are psychosocial and pharmacological approaches, and I want to be mindful of our time. I think we want to stop before 1:30, I think. Okay, all right. So, some of this stuff, and by the way, if you want a copy of this handout, I apologize, I didn't have time to make handouts, but my email is stephen.batki, B-A-T-K-I, at ucsf.edu. And I think, among us, we can figure out ways to get you a handout. But you can certainly email me at stephen.batki@ucsf.edu, and I'd be happy to send you a copy of this, because I'm going to fly through some of the information about seeking safety, and you may want to refer to that or check it out. So there's been a recent review in the past year on psychological treatments for having PTSD and substance use together. And traditionally, there's a real difficulty in doing controlled trials of psychotherapies because it's very difficult sometimes to show differences between your intervention that you're doing research on, the psychotherapy that you're focusing on, and some control condition. And the reason for that is because just about any attention is really good for people who have mental illness. And especially the kind of attention that you get in the research study is so structured, it's so supportive, there's so much monitoring, there's so much people get that it's very hard to show even if a therapy is better in some way than another control intervention, it can be difficult to show a difference. So the usual outcomes when you look at two different kinds of psychotherapies for different conditions is that they both help. And it's hard to show a statistically significant difference between the two. Anyway, this is a recent meta-analysis looking at 17 studies of psychotherapies for substance use and PTSD. And some were trauma-focused. So by trauma-focused, it means exposure, so like imaginal exposure, where you expose people to images associated with a particular stress they have. If it's a veteran who had some military or combat trauma, it might be images of that kind of trauma, and leading to progressive desensitization, having people write out their traumatic experience and re-experiencing that with a therapist. There are various techniques that are used to progressively desensitize people to the traumatic experience. So there have been various studies looking at trauma-focused therapies, and then there are non-trauma-focused therapies. Seeking safety is one of them. Certain types of cognitive behavioral therapies have been another. So in general, what do these meta-analyses of these psychotherapies show? Well, that there are pre-post reductions for both PTSD symptoms and or substance use disorder symptoms. So in these studies, these psychotherapies work. In other words, there's a reduction of symptoms. But most of these treatments didn't prove superior to regular substance use treatment. Although there's some preliminary evidence that some patients benefit from trauma-focused treatments, it's just difficult to predict which patients need the more specific trauma-focused treatments, which patients do pretty much just as well with the substance use treatments. Again, these are in the context of research studies, which are generally much more structured, offer much more attention, than regular clinical care for substance use disorders. And the conclusion was the lack of methodologically sound treatment trials makes it difficult to draw firm conclusions about which psychotherapy is best for PTSD and substance use as they co-occur. All we know is people get better after these therapies than before, but we don't really know which one's better than which or which patients exactly benefit. I just wanted to say a word about seeking safety, and I'm going to show several very text-dense slides, which I'm not going to go through, but which I can send you if you're interested in these summaries of seeking safety. So seeking safety is a present-focused therapy to help people attain safety from trauma, PTSD, and substance abuse. It's been conducted in group and individual formats for both women and men. It began in 1992, developed by Lisa Najovitz, again, a psychologist in Boston at Harvard. There are 25 topics that are covered in these seeking safety group and individual presentations. And just as examples, they include asking for help, setting boundaries in relationships, getting others to support your recovery, healthy relationships, coping with triggers. So a lot of this, detaching from emotional pain, a lot of it is pretty generic. It can apply to really all substance use patients, not just those who also have co-occurring trauma. But the key principles are safety, so helping clients feel safe in discussing their substance use, working discussing their trauma in front of others. Integrated treatment, so trying to address both the PTSD and substance use at the same time, rather than another model which would say, well, you have to get your substance abuse treatment first. First you have to get abstinent, sober, then we can address the PTSD. So this is very much different from that. There's a focus on ideals, personal ideals, values, and then there are 4 content areas: cognitive, behavioral, interpersonal, and case management, and attention to clinician processes, countertransfer, and so on. So a lot of this is just standard good psychotherapy with many elements that really can apply to all patients with substance use disorders, but there's a specific focus on the co-occurrence. There have been lots of studies, very few controlled trials. Most of them are sort of pre-post. And of the 11 studies that were covered in a recent review, 4 were controlled trials. Of the studies, most of them showed positive outcomes. But again, it's the same sort of thing as I was referring to earlier, that they show improvement from before to after, rather than showing that the seeking safety is clearly superior to some other psychotherapy. But I think it's enough to say that there's a lot of evidence that seeking safety outperformed treatment as usual. And this is probably, seeking safety is probably the most commonly applied psychotherapy in the United States currently for individuals with PTSD and substance use disorders. So I want to get to another related question, which is, if you do treat PTSD, do treatment improvements in PTSD severity affect substance use outcomes? So if you improve the PTSD, does it have any bearing on how people do in terms of substance use? And the answer to that seems to be yes, and this was a recent study in American Journal of Psychiatry from 2 years ago by Denise Hean, who, this was part of the NIDA, National Institute on Drug Abuse Clinical Trials Network, multi-center study with about 350 women who were assigned to 12 sessions of either trauma-focused therapy or health education as sort of a control. And they looked at PTSD and substance use over time. And PTSD severity reductions were more likely to be associated with substance use improvement, whereas there was minimal evidence that substance use symptom reduction improved PTSD symptoms. So the directionality in this particular study appeared to be that improving PTSD symptoms had more of an impact on substance use than improving substance use symptoms had an impact on PTSD. And they support the self-medication model. There have been a lot of critiques of this study. It's hard to just come away with this with one picture that says PTSD drives substance use, but there's certainly some evidence for if you improve PTSD symptoms, it certainly helps with substance use. I also want to just touch on another study, which is even more recent. This is just from this past year, 2012, from JAMA. And I think this study is really interesting. It's integrated exposure-based therapy for co-occurring PTSD and substance dependence. It's an Australian study, 130 patients. The objective was, what happens if you integrate an exposure-based therapy with substance use? And the reason this question was interesting is because there's been a lot of concern that people who are early in recovery, you shouldn't expose them to exposure-based PTSD treatments because you might induce cues that would trigger relapse through distress that would be raised by the exposure therapy. And so what this study found was that it was a controlled trial, and both groups, both the treatment group and the control group, improved in PTSD symptoms, but the treatment group, the group that got the exposure therapy, improved significantly more in terms of PTSD. And both groups improved, both the control group that got the non-specific treatment for PTSD and the group that got the exposure therapy, they both did the same in substance use. So it did not show that the exposure-based therapy improved substance use, but it showed that it didn't worsen substance use. So exposure-based treatment in this study improved PTSD symptoms significantly more than a control condition without worsening substance use, which I think is an interesting and important and reassuring thing to know about providing exposure-based treatments for PTSD to folks who have substance use. So I'm going to now move to medications and just touch on that in the remaining time that we have left. In substance use, we can use medications for lots of different stages of treating intoxication. Certainly, we do a lot of withdrawal here, detoxification treatments, but getting people to stop, so abstinence initiation or use reduction, is a major focus of ongoing outpatient treatment, and of course, preventing relapse in people who've stopped using. These are the main focus areas for pharmacotherapy. And in pharmacotherapy, in terms of clear evidence and FDA-approved treatments, there are some substances that we have proven medical treatments for and others that we don't. We don't really have any FDA-approved treatments for cocaine, methamphetamine, hallucinogens, cannabis, solvents, and inhalants. But we do have very good proven FDA-approved therapies for opioids, alcohol, and nicotine. Benzodiazepines we have good evidence-based treatments for in terms of substitution treatments, either with anticonvulsants or we use short-term treatment occasionally with long-acting barbiturates or long-acting benzodiazepines to just taper people off. So for opioids, alcohol, and tobacco, we have good evidence-based treatments. We don't for some of these other drugs. And why would we want to use medications in people who have both substance use and PTSD? Well, obviously to reduce substance use, to help prevent relapse to alcohol or opiates, heroin, or other drugs, but also perhaps to reduce PTSD symptoms. And I'm not going to get today, we don't have time to get into a broad discussion of what are the various medical treatments for PTSD. We've talked about the psychosocial treatments. But it's fair to say that the medical treatments for PTSD are pretty bad, meaning that they're not very effective. It's terribly difficult to predict for whom they're effective. And this is something we face at the VA all the time, is just trying one medication after another, hoping to find something. I mentioned a group of medications, those that affect adrenaline, like the medicine prazosin, which reduces nightmares in PTSD. And then, of course, the antidepressants like venlafaxine, Effexor, or paroxetine, Paxil, sertraline, Zoloft. There's some evidence that they help more than placebo in PTSD. But as we look at medications to treat addiction, we're also hoping that they might affect some of the PTSD symptoms as well. And there's been very little work in this. There really, you could probably count on the fingers of one hand, published studies that give you any evidence about what happens when you give medicine for PTSD and alcohol use. I'm not going to spend too much time. There's been the major study has been one using sertraline or Zoloft for patients with PTSD and alcohol use. And what this showed was that patients, about half the patients responded, but in this study, there was no real overall response. There was no real overall difference between those that got Zoloft, sertraline, and those that got placebo. That as a whole, if you looked at the Zoloft group and the placebo group, there was no difference in terms of benefit for PTSD and certainly reduction in alcohol use. But if you looked at subsets of the patients, those who had less severe alcohol use and early onset PTSD were helped by Zoloft, but worrisome was that in those with more severe alcohol and later onset PTSD, they actually did worse. They drank more on Zoloft than they did with placebo. So the kind of net result of this is that overall there's no benefit. Some patients actually do worse on Zoloft than placebo. Some patients do better. So the picture is very muddy, and this is one of the best studies that we have. So what are some other possible medications that might help treat alcohol dependence and PTSD? Well, we have alcohol medications, Antabuse, naltrexone, Camprol. Topiramate is one that we're interested in. It's not FDA approved, but there's some big studies that show topiramate or Topamax is helpful in reducing alcohol use. And then we have some PTSD pharmacotherapies, and topiramate, Topamax has been one of those. So topiramate is one of the medicines that showed some evidence looking at PTSD, looking at alcohol separately. There's been some evidence that it might work for each disorder. I'm going to skip over these other studies, and I just wanted to say a word about a study that we finished recently, and we're now planning a larger version of this. But basically, this is with veterans who have PTSD and alcohol dependence, and giving them the medication topiramate in addition to weekly motivational counseling over 12 weeks. And it's one of these randomized parallel group placebo-controlled studies where everybody gets the psychotherapy, and then half the people get the medication, half the people get placebo. And they're measured every week for PTSD symptoms, for how much alcohol they're using. And this was a study that we completed this spring. And interestingly enough, at baseline, when we measured the CAPS, that's the clinician, that's basically the gold standard PTSD symptom scale. But there were significant relationships between some PTSD symptoms like re-experiencing and the level of alcohol use, the percent heavy drinking days, and also some other relationships between hyperarousal and alcohol, which would tend to support that the more symptomatic people are with PTSD, whether it's re-experiencing or hyperarousal, the more likely they're to be drinking heavily. So again, this could be either the self-medication hypothesis being proven again, that people who are suffering more with PTSD, re-experiencing hyperarousal, drink more heavily. Or it could be if you're drinking more heavily, you're suffering more from PTSD symptoms because you're messing yourself up with alcohol. This is some data from a postdoc working with us, Dr. Adrian Hines, that is being presented actually today in Los Angeles at the International Society on Traumatic Stress Studies, that is looking at this sample of 30 veterans. And what this basically shows is that there's a really good relationship between alcohol use, in this case alcohol craving, and PTSD symptom severity. That's pretty significant. And also, as PTSD symptom severity goes down over the 12 weeks of the study, alcohol craving also goes down. But more interesting than that, Adrian did an analysis that showed that it seemed to be the PTSD symptoms that were driving the alcohol craving. She did some temporal sequencing of this data. So it's not just a correlation, but it really seemed that the changes in PTSD symptoms preceded the changes in alcohol craving, which was interesting. So this is the current study. I'm not going to say much about the patients. They're mostly men, just a few women in this 30-sample study. In the interest of time, I'm not going to go over this in great detail, but just to show that the drinking, these veterans on average, their percent drinking days in the past 90 days, the median was 87%, and the average drinks per week was about 102. So it was a heavy drinking population. The average. The median was a little bit lower. The median was 85. So that's a lot of drinking. And their PTSD symptoms were really high. Their CAPS total score, the median was 80, and that's in the severe range in terms of PTSD. Most of these were Vietnam-era vets. About a quarter were Iraq, Afghanistan era.
What does CAPS mean?
CAPS is the PTSD. I'm forgetting the acronym. Maybe somebody can help me here, but it's the clinical something PTSD scale. And it establishes a DSM-4 diagnosis. It's the gold standard PTSD measure that's used in most research studies to establish PTSD diagnoses. And so what happened with the study? Well, this shows the outcome over 12 weeks of topiramate is the red line, placebo is the blue line. People start out at around the same level. This is days per week of drinking, the mean and median. And this turned out to be a statistically significant difference, and this medication helped reduce alcohol use significantly more than did placebo over 12 weeks of treatment. Interestingly enough, it also reduced craving significantly. The red line, this is a standard alcohol craving scale. The red line is topiramate, the blue is placebo. So alcohol use and alcohol craving were both diminished. Everybody got better, like in most studies, but the topiramate group got better at a greater rate. And then very interestingly, although we didn't achieve significance, but PTSD checklist scores were also lower in the medication group than in the control. We had very good retention in this study as well. Just another interesting factor, we're looking at various measures of impulsivity with the hypothesis that medications like topiramate can reduce impulsive behavior, impulsive thinking, and we seem to be finding that the red line here is topiramate, and this is from baseline to 12 weeks, looking at changes in this impulsivity measure, the means and the medians, and what you see here is that the topiramate group, the slope is much steeper in terms of decline in self-reported alcohol-related impulsive behavior, which we find encouraging. So, in conclusion, at this point in time, psychological treatments are the main treatment modalities for PTSD and probably for the co-occurrence of PTSD and substance use. There are proven pharmacotherapies for each of these conditions separately, but not much is known about how they might work on the interaction of these two conditions. And there's a lot of room for more research. And ways to reduce impulsivity, risky and poor decision-making may be really important components. An area that we're exploring right now is combining neurocognitive training using various computer-delivered modalities and perhaps combining them with medications that might also reduce impulsivity as a way to see whether the two combined might be better than either alone. So that's all that I'd prepared, and I'm available for any comments or suggestions or questions that you folks might have. Thank you very much.
Yeah, I read that they're doing some research with Iraq veterans and PTSD with MDMA. You know anything about that?
I know very little about that. There's some open label work that actually I think has been done fairly responsibly, but it's not an area that I'm very expert in. So other than I know that there's interest in doing more of that work with MDMA with other hallucinogens. Yeah.
Is any of the research that you're involved with looking at, I've read a little bit and heard a little bit about the, minus actual real trauma, what kind of trauma just drug abuse alone does to a person's brain? That, in fact, if someone can have PTSD simply from using drugs and the experiences that drug cause that, not
All right, so the question is what kind of direct effects could substances have that could produce perhaps PTSD-like symptoms? And I think, there's not a lot of information about that. Most of the information about how drugs lead to PTSD is through exposure to traumatic events that come as consequences of the high-risk things that one does in the midst of addiction. But it's possible that stimulants during intoxication, particularly cocaine or methamphetamine, can trigger these brain alarm systems very intensely, and then can produce a phenomenon called kindling, where you become more and more sensitized to fearful, anxious, neurochemical changes in your own brain to the point where they begin to occur spontaneously even without substance use. An example, it's not so clear with PTSD, but with panic attacks, this has been shown that even if you don't have panic attacks to begin with, in some individuals, cocaine use can induce panic attacks during episodes of cocaine use. And then in a subset of these folks, the panic attacks persist after stopping cocaine use through a phenomenon known as kindling or sensitization. So
Some sort of damage is going on in the brain.
Yes.
It's a simple result of using the drug, not experiencing
Yes.
trauma, right?
Yes, not well characterized, but I think there's a good deal of evidence for that. And if it's true for panic, then it's reasonable to think it's true for other forms of anxiety disorders like PTSD. Yeah.
In the last study you cited with the veterans that are still drinking
Yes.
taking the topiramate.
Yes.
What is it?
Topiramate.
Topiramate,
Yeah.
and showed a reduction both in their cravings and in the number of drinks per
Yes.
week. Is there going to be, or has there been a study with those who are abstinent or in sobriety using
Yeah.
this?
So the question was, has there been a study looking at people, not those who are actively drinking at the time that they come into a study for medication, but those who have stopped? And we've now been funded to do a much larger version of this, 150-patient study that we're just beginning. It'll be over the next 4 years. And for our purposes, we need people who are actively drinking, but there are also a subset of those who've stopped in the last week, for example. They might have been drinking in the 30 days prior to coming to the study. Even in the sample I showed, some people are already abstinent in the 7 days prior to coming into the study, although they had been drinking at some time in the 30 days prior.
Because my experience as
Yeah.
a clinician is that when people are actively behaving addictively, whether with substances or other
Yes.
ways, and taking psychoactive medication, that we don't get very good results or clear pictures of the efficacy of the meds because of the
Yeah.
influence of the other.
Right. So the comment is that when people are drinking at the same time that they're taking psychiatric medications, that it's very hard to get, for example, an antidepressant or an anti-anxiety response. And that's true. However, if the medication is meant specifically to reduce the substance use, then it should still be working. Now, the truth of it is that we don't always have the luxury of having people arrive at our treatments in abstinence. In other words, in the world, we have to deal with these people who are actively using. But I think, to answer your question, there's evidence that, and I think you might be getting to this, that people who've stopped do much better at being abstinent in the 3 months following starting a study than people who are still drinking at the time that they come into a study. And that's true with pretty much all of the alcohol treatment medications, that if there's even as short as a 4-day period of abstinence before medications are started, that those people have a much better outcome. Now, why is that? Is that because those people are different to begin with? They're better patients, they're more motivated, they've been able to stop? Is it that they're now biologically different because they've stopped? It's a complex, it's difficult to answer that question. Okay, everybody's giving me the 1 minute sign.
All right.
Yeah.
I've had a lot of good results with all three, TBI, PTSD, and also substance use with a technique called lens neurofeedback. I just didn't know if you were familiar with it.
No, I'm not. Is that, do you work with Dr. Schiller or?
No, I work with Echo Rock Therapy Center. There's a husband and wife there who do it. They use a lactate the brain, and they map the brain and then read what the levels of operation. I can tell you more about it.
Okay. Yeah, and this whole topic of neurofeedback is a recently developing modality, and I think there's some preliminary evidence that it might help some people.
Are you familiar with Gabriel Mathi's book?
I think Albert just gave me the timeout sign. So thank you again for your attention.
The realm of the hungry ghost.